Hello and welcome to another Pilates Hour. We're excited to be with you this week, and we're going to go into some more physiology, particularly of the nervous system. And I guess I'm a little overzealous. I realize that I'm going to try to teach about 6 chapters out of the Human Physiology and Pathology book in about 50 minutes. And though that's actually impossible, I do want to create the environment for all of us to be able to understand at least nomenclature and some common terms that we can use when we're talking about clients that suffer from neurological impairment. So let's get started. We're going to jump right in. We are going to be looking at the nervous system, and the nervous system for us is going to compose the central nervous system, the sensory nervous system, the autonomic nervous system. We've heard a lot of people talk about sympathetic and parasympathetic nervous system. And then we're going to also cover the somatic nervous system. And at the very end, we're going to look at some of the common pathologies that we see of the neurological system and hopefully put things together where we can actually see, oh, that's a problem in the dopamine center and the central nervous system that's causing the lack of dopamine for Parkinson's or those kind of things. And we can understand a little bit better. So as we continue to talk about pathologies and we talk about treatment plans or pathologies, it will make more sense because we have the right nomenclature. So we often talk about 2 parts of the nervous system. We talk about the central nervous system and we talk about the peripheral nervous system. So the central nervous system is made up of the brain and the spinal cord. That's what makes up the central nervous system. Peripheral nervous system are going to be all the nerves that either come out from the spinal cord and the brain or that feed into the spinal cord or the brain. And that helps us to better understand. When we say central, sometimes people think it's only the brain, but it also includes the spinal cord. And the brain and the spinal cord are surrounded by what's called dura. And dura is the protective sheath that contains some of the blood supply and the nutrients that the nervous system needs and protects the central nervous system. As it comes out into the peripheral nervous system, these are surrounded by what's called epineurium, and that's a continuum of that connective tissue. So remember back a couple weeks, and we were talking to Dr. Carol Davis, and we were talking about how the fascial system or the myofascial and connective tissue surround all the organs and all the systems, including the nervous system. So we go down to the basic unit in the nervous system. It's the nerve. And here we can look at what we refer to as the axon and the cell body or the nerve cell body of the nerve. It then has the cell body. The axon is the branch, and this is a nucleated or myelinated nerve. So the myelin sheath is surrounding it. This is what allows for nerve conduction to be faster. Cells that do not have myelin are slower conduction. And then we have the dendrites. So what's typically happening is some message is coming into the cell body. That message then is going to create a response that causes a message to be sent down the axon, and then it is delivered through a neurochemical transfer, sometimes things like norepinephrine, epinephrine, dopamine, serotonin, other types of neurotransmitters to the end target. Now, the end target could be an organ, it could be a muscle, it could be another nerve, it could be the central nervous system. This is just the basic communication chain. So when we talk about diseases that actually destroy the myelin, like multiple sclerosis, that's going to cause a lack of nerve conduction. Or if we talk about destruction of the anterior horn cell or the nucleus of the cell, like ALS or Lou Gehrig's disease, we're talking about this body. If we look at where we have problems transferring or communicating information, at the end, that could be something along the lines of Graves' disease, or where there's a loss of conduction between the nerve ending and the target cells, particularly the muscles. We look at the brain, and again, we could spend years, and most people do spend years studying the brain to understand. We can break it into its lobes. Now, the frontal lobe is responsible in this region here as the motor cortex. This is the prefrontal cortex just in front of it. And then we have the frontal, where a lot of our decision making, and when we talk about cognitive behavior, cognitive learning, socialization happens here in the frontal lobe. So when we talk about things like autism is thought to be some lack of development in this frontal lobe, right? Where the socialization, understanding how people react, how to interpret body language, how to interpret people's facial expressions. When we come back in the parietal lobe, this first part here is the sensory cortex. So just again, reiterating, motor cortex is here in the frontal lobe, sensory cortex is here in the parietal lobe, and they communicate. And think of sensory coming in and motor signals going out to the muscles. And you've probably heard of the homunculus. The homunculus is a map of the human body in the nervous system. So the neurosurgeon can go in and literally identify which part of the body this relates to in the motor or movement, and can also identify here what part of the body identifies with sensory. So if you did a pinprick on your finger, where the hand is demonstrated or modeled on the parietal lobe or the sensory cortex, would have a direct correlation. We know that sensory, the largest representation of sensory is going to be in the lips, the hands, the feet, and the genitalia. So they make up, when you look at the map, it's very disproportionate. And the same thing with motor. The areas that we tend to move the most tend to have the largest representation in the homunculus. As we move further back into the part here is occipital lobe, and this is famous for having the visual cortex. So a lot of times people, their eyes and their optic nerve can conduct signals back into the visual cortex in the occipital lobe, but there could be a disruption in the conduction there, and they still could be neurologically blind, even if their eyes work. So there are, this is the area that visual cortex takes place. In the temporal lobe, we have our auditory cortex. We think of things like proprioception, the inner ear, sound interpretation. Same thing, the ear can capture the sound, it can vibrate, but it has to be interpreted inside the auditory cortex to be able to be interpreted and then processed. And the advanced processing is taking place again up here in the cortex. So when there's a volitional interpretation, meaning I want to understand what I'm seeing, or what I'm feeling, or what I'm tasting, or how that's going to make me react for safety purposes, a lot of that cognitive action is happening here in the frontal lobe. Down in the bottom here in the cerebellum is responsible a lot for our coordination. So this is where proprioceptive centers come in, and they help us interpret positions of our body. If you all lift your arm up right now, or you close your eyes, you lift your arm up, you know that your arm is going up. Or if I took your thumb and I lifted your thumb up and down multiple times and stopped in one of those positions, even with your eyes closed, you're going to know where your body is. And that's the proprioceptive system and the coordination system that's taking place here in the cerebellum. And then in the more primitive brain is where we have our autonomic nervous system. And this is also where a lot of our hormones are released and managed, just above the spinal cord. So when sensory information comes in that has to do with the autonomic nervous system, things like digestion or survival or reproduction or automatic maintenance of the heart and breathing rhythms, all of those are happening here in the brainstem. And then the spinal cord goes down, and that's where we look at the spinal cord, and we know the spinal cord runs through the protective mechanism around it, which is an articulating set of 24 bones called the vertebra or the spine. There are, coming from the brain, there are going to be in the head, there's going to be 7 cervical vertebrae. There's going to be 12 thoracic, 5 lumbar, and then a few sacrum. And what happens is as the spinal cord comes down, if we look at the x-ray, we can see a little bit better. The spinal cord comes down from the midbrain, and the dark part of this is actually the nerves themselves. The fluid around it is the cerebellar fluid, and the lining around it is going to be the dura. And what happens is segmentally, these nerves are coming out through the foramina. Foramina is another word for holes that are inside in between the vertebra. And they go to respective areas and territories on the body. So we see here the cervical spine has sensory for the head, for the face, the diaphragm, down into the arms, the wrists, the fingers, the triceps. The whole upper extremity is managed pretty much by the cervical nerves, right? So C1 to C8 is a nerve. Even though there's 7 vertebrae, there's 8 nerves. The thoracic pretty much is maintaining just the thoracic region. So it's segmental. If we drew a map of the sensory and the motor, we would see a direct correlation with these parts of the body that are horizontally organized with that segmental level. And then the lumbar and the sacrum, we know, go down to the pelvis and into the lower extremity. So if somebody had an injury to, say, an L5 nerve root, they might notice difficulty with drop foot or lack of sensation in their foot, and possibly some spasms or those kind of things. A spinal cord injury, we'll talk about a little bit later, could be a complete injury to the central spinal cord. Excuse me. I'll say that again. A central lesion on the spinal cord would be into the central canal or the spinal cord itself. Injury to the nerves that are coming out often are referred to peripheral. So if you had your people have a disc problem, the disc often is putting pressure on the foraminal outlet where the nerve is coming out down to the leg and putting pressure, and it's affecting the leg. Versus, let's say, a central herniation in the neck that might be pushing on the spinal cord right here in the middle of the neck that could be causing paralysis. It could be causing loss of sensation, loss of proprioception, all the information, both sensory coming up and motor going down, can be impeded by that central obstruction, right? And this is where we often hear people talking about, oh, I have a herniated disc, and they might have a nerve root encroachment. A nerve root encroachment is going to be more the peripheral nerve, or a central encroachment or a central nerve lesion is going to be more in the spinal cord, okay? And then we identify them by levels. So each of these levels coordinate with a part of the body that we can test and see, do they have the sensory? Do they have proprioception? Do they feel temperature? Do they have motor skills? Can they actually have strength pinching their finger together? Can they resist their arm up in a manual muscle test? These are all the ways clinically that we try to identify diagnostically, where is that lesion? Is this a central lesion? Is it a peripheral lesion? Where do we find it? When we talk about peripheral nervous system again is anything coming out from the brain or the brain stem or the spinal cord that goes out or is coming in from the body into the brain stem or the spinal cord. So we can break that up into three areas, and we're going to talk about each of these areas. The autonomic nervous system, and we've talked about this as the sympathetic and parasympathetic. So when somebody says, what do you, when you're in limbic mode, or you get really excited, or you're afraid, or you're scared, or you're in survival mode, you are in sympathetic mode. The sympathetic system is a survival mechanism that automatically will increase your heart rate, cause vasoconstriction, increase your alertness, your vision, and it will often lead to an incredible amount of energy from having epinephrine released throughout your body. So that's a very autonomic response to some kind of perceived threat or excitement. The parasympathetic is its balancer. So these are antagonistic. They work opposite of each other. For example, last week we talked about the heart, and we said that when there is a parasympathetic or a sympathetic message coming down from the brain, it is going to influence the pacemaker of the heart. So if it's sympathetic coming into the heart, it's going to increase the heart rate. If it's parasympathetic coming into the heart, it's going to decrease the heart rate. And so we can look at this particular scale here and realize that almost all of the sympathetic ganglion are located in the thoracic spine, anteriorly down into like L1, L2, and that the parasympathetic is located in the base of the brain, or the brain stem, and also down in the sacrum or coccyx area. And when we think about the parasympathetic, you've often heard of the vagal nerve or the vagus nerve. And the vagal nerve is many nerves, but they basically control a lot of the digestion and including other parts of the heart and respiration that are controlled by this brain center or autonomic nervous center. So they send messages to these parts of the body. And remember that when we're in sympathetic mode, we're excited. That means that activities that happen in rest mode, like reproduction organs, digestion, cleansing the body, filtration of the liver and the kidneys, those are going to slow down when we're in sympathetic mode. When we're in parasympathetic mode, we're going to be able to rest and to be able to basically cleanse our body. So here's a big issue that we can talk about, right? We know that in our world today, a lot of us are living in sympathetic mode all day long. And sympathetic mode is going to squirt out a massive amount from the kidneys and the adrenal glands of cortisone. Now, cortisone is natural and good. It should be excreted in the morning, and it sort of lasts us throughout the day, and it brings a certain level of alertness to our body. However, when we are in constant adrenal stimulation and we are filled with cortisol, that is not a healthy situation. And we know that meditation or mindful movement that we all teach could, even 15, 30 minutes a day, can reset the cortisol excretion from the adrenal gland and can minimize the negative effects of being in cortisol overload, right? That's what we want to try to avoid. The next part of the central nervous system we talk about is the sensory nervous system. And then the last one is the somatic nervous system, which is the motor. And I'm going to take a look right now with you at the sensory. So sensory should make a lot of sense when we think of things like vision, hearing, smell, taste, touch, proprioception, stretch reflexes. All of these things are giving heat, pressure, giving us information of our surroundings and our environment. And so it's very important that we understand that sensory then comes into, remember we said the sensory cortex, and is being interpreted. So for example, smell comes into olfactory, visual goes into optic, into the back of the brain, in the occipital lobe. And then we have the sensory of the body coming into the sensory part of the parietal lobe. And all of this is integrated to be able to help us have an understanding of what is going on around us. These include things like mechanoreceptors. So when we're teaching Pilates and we're putting the feet onto the foot bar, there's mechanoreceptors that bear weight and tell us, oh, there's pressure on your heels. Or there are stretch receptors in your muscles called muscle spindle fibers, and there's Golgi organ tendon organs inside of your tendons that tell us where our body is and how it's oriented with gravity, for example. And one we talked about recently with Dr. Davis is that in the fascial tissue, we believe that one of the greatest proprioceptive organs is the Golgi organs that are found inside the fascia that are sort of like a balance kind of thing that tell us how we are relating to gravity in our vertical posture as bipedal animals. Skin also gives us a lot of awareness. So we know that even clothes and leaning up against the wall or things on our feet give us proprioception and awareness. And we can know where we are in space, and that's really important. However, there's certain parts of our body that we don't do so well in. We've talked about this before as well. For example, in the pelvic floor, when we did the research looking at active volitional contraction of the pelvic floor, the pubococcygeus muscle, what happens when somebody does an active contraction of their pelvic floor, or what they think happens, right? So areas in our body that we are less familiar with or that we do not experience frequently, we are going to have less proprioception or less awareness of that area. What we found was that with 250 Pilates teachers, female Pilates teachers, that we asked to do a volitional contraction in their pelvic floor, 45% of them were not able to do it or did not correlate with it. They thought they were lifting their pelvic floor. They lifted their hand, and the ultrasound said, no, they're pushing it down or they're inactive. And so this is something that we're very interested in, is how do we as Pilates teachers create greater awareness, greater proprioception, greater sensory? How do we match what we see with what we feel in our bodies, right? A lot of times people see themselves, but they don't realize that what they're actually seeing is distorted. So they might think they look skinny, they might think they look big, they might think that they are standing tall, and then we take a picture of them or we videotape them, and they're like, wow, I had no idea my posture was that bad or was that good, or that I was not moving that far, that my knees were bent when I was doing that activity. And this is where we as Pilates teachers can provide, especially in these neurological impairments, external feedback to promote internal feedback. We are the external feedback. Can you lengthen your leg a little bit more? Here's a picture of your posture. Can you think of lifting through the back of the spine a little bit more? Can you get your eyes a little more horizontal to gravity? So these are the kind of things we give externally, but what they feel and what they have internally is really what is the most valuable. And that's what's happening here in this sensory, is we're aligning their sensory through many different mechanisms of sensory: sound, touch, vision, proprioception, even smell and taste can be effective for us in the nervous system. And so this is the information coming from the outside in. This next slide is taking a look at some of the information of how it goes out, right? So if we take a look at this, we can see that up here on the top is a somatic nerve that is basically a motor nerve. So this is coming from the spinal cord to a muscle. And what's going to happen is we have the nucleus, right? The axon cell, the nucleus of the cell here. We have the axon coming down. It is myelinated in motor nerves. And then it releases acetylcholine directly into the muscle, and that causes an action potential to go on the muscle and create tension or a contract of that muscle, right? As we talked about with Dr. Davis a couple of weeks ago, and she sort of blew all of our minds away, was thinking of how it is more of an elastic relationship to tension produced by the contraction of the muscle that is stimulated by the nerve, the motor nerve coming to it. It's interesting that at the same time that we have a motor nerve going down to a muscle, there is a sensory nerve inside the muscle called a muscle spindle fiber. We've talked about this before in the muscle physiology section, that is going to come back up into the spinal cord as a sensory organ, and it's going to relate the tension curve or the tension relation to the muscle contraction. So that means that if we carry something that's too heavy, we thought it was 10 pounds and it was 20 pounds, that reaction is going to happen in about 50 to 100 milliseconds, and it will cause an increase in motor response to get more muscles to fire to resist the miscalculated weight. Now, the way the body works is we have what's called memory. We have muscle memory, we have long-term memory, we have short-term memory. And in the idea of where our body is as children, we start learning, right? Every time we fall down as a toddler, learning how to orientate ourselves to gravity or to lift things or how to counterbalance ourselves on a single leg or to walk, run, climb, all the activities we do are all these things that are basically educated in our nervous system. And they are task related. And the task doesn't know that it's going to a muscle fiber per se, like it's going to go to the piriformis for a rotation or to decelerate the hip. What it knows is the task. This becomes very, very important. I can't emphasize this enough in neuromuscular science, is that when we train a muscle independent contraction, we are not training function. That's why you hear me say this all the time. It's not that the muscle is not important, but the muscle trains by the task. And that also trains the amount or the load or the intensity of the contraction with the common human goal to move efficiently and accomplish the task. Never are we doing a max voluntary contraction to do things like bring a fork to our mouth. And how many muscles are involved in that? One day I wrote a paper for my neuroscience class, and I chose just a simple kiss. And it ended up being a 30-page document of talking about the nerves and the nerve conduction and how it impacted things like our thought or our desires or our motivation to kiss that person that we love and what was involved in it. Now, we all know that whenever we had our first kiss wasn't a 30-page thing, right? It was literally in a second. We might have bumped our teeth or our noses, or we both turned our head the same way. And then what happened is very quickly we learned, oh, when we kiss, I'm going to turn my head to the right, she's going to turn her head to the right, and we can actually match our lips up just fine, right? And maybe that kiss was too wet or that mouth was too open or whatever it is. We learn very quickly by the task. We're not going through thinking of, okay, my hormones are being released. The dopamine is getting me excited to think about a potential of a kiss. I'm going to now contract shift my weight forward. I'm going to use my buccal muscle to pucker, and I'm going to, lean forward with some flexion and deceleration in the back of my neck to be able to do that kiss. That's a 30-page discourse, right? So what we're looking at here is that when we talk about somatic nerves and sensory nerves, this is happening automatically tied into the task. And the more repetitive the task is, the more automatic it is, the more that it comes down into what we call central pattern generators in the spinal cord to be able to do things like walking and swimming and running that are more repetitive and rhythmic actions. When we come down to the next level here, we're looking at the autonomic nervous system again, right? So here we see the sympathetic, and the sympathetic, as I mentioned, these ganglia, these nerves are located just in front of the thoracic spine in the rib cage. So the costovertebral joint anteriorly of the rib cage is where these exist. And they have a very short presynaptic that's going to connect to a ganglion, a sympathetic ganglion. And then it's going to have a long postsynaptic that's going to go to an organ or to a muscle or to a blood source or some kind of target, the heart, that it's going to release norepinephrine and cause a stimulation to that organ or that target tissue. The interesting thing with the parasympathetic is the parasympathetic, I mentioned, is located in the brainstem, right? And also down the sacrum. And it has a very long presynaptic. And that presynaptic fiber then connects to the postganglion, and that has a very short that's going to release acetylcholine to that target tissue. So again, this is usually going to be the vagus nerve, and this is going to be, this is the vagus nerve, and this is going to be the sympathetic nerves that are coming out of the thoracic spine. There is one other example of the sympathetic where there is a direct link to the organ on top of the kidneys that release directly into the bloodstream epinephrine. And that's why when we're scared, we can get adrenaline into all of our tissues very quickly and be able to respond for a survival mode. So this is a unique feature of the sympathetic nervous system, but nonetheless, very much part of how our nervous system works. So a couple key things I want to talk about before we go into some of the pathologies, the last half of this webinar. The first thing is, how do we basically know if we have a healthy nervous system, right? So the nervous system is so complex. I was just watching a video of a brain surgery doing an implant for Parkinson's disease, a stimulator. And it's like the science of what we're doing these days with radiographic guiding and different types of mag stim, that we can identify exactly where these centers are in the brain and in the nervous system for us to be able to treat them more effectively. So to me, when I think of the communication of it, we talk about action potentials. Now, action potentials is the nerve conduction. So an action potential is basically a chemical electrical charge that is going to send a message in one direction. Doesn't send it in both directions. But we have sensory nerves that are sending messages through action potentials to the central nervous system, and we have action potentials and messages coming away from the central nervous system. And that's a nice way of thinking about it. So when we have sensory problems, we have vision loss, we lose taste. For example, the COVID virus affected people's taste and smell. So that would have affected things like the olfactory gland, or those things where there was a change in the interpretation of whether things tasted good or didn't taste at all or tasted bad, right? Hearing, the same thing. We have sound waves come into our ear, our outer ear. The inner ear has to interpret that, and it's going to send messages into the auditory cortex to be able to interpret it. When we hear new sounds or new words, for example, the brain has to go through a process of trying to problem solve that. So most of our problem solving and learning how to make things work in our life are happening in the brain. Any kind of volitional thing, if I said to you, I gave you a command, bring your finger to your nose, right? And everybody brought their finger to their nose. So do it. I can't see you, but I'm trusting that you're doing it. You had to interpret my command through your ear into the auditory cortex, send it up to the front to understand what I'm asking you, right? And then you go to the motor cortex of something you learned a long time ago, is to bring your finger to your nose. Now, if there's an impairment in any part of that chain, let's say that you don't hear. Well, I could speak all I want, but you would not know what the command is unless I made a sign, or I said, do as I'm doing somehow, or I wrote it and you saw with your eyes, and then your eyes are interpreting, oh, Brent's bringing his finger to his nose. I'm going to bring my finger to my nose. That thought process is happening up in the frontal lobe and in the motor cortex. And the motor cortex then tells us to bring our finger there. Now, if it's a new movement, and let's say that we're less than a year old and they're trying to copy somebody to bring a spoon to our mouth or our finger to our nose, we are heavily dependent upon the sensory, the proprioception, because you see kids, they'll miss their mouth and they'll miss their head, or they'll put an ice cream cone on their chin or on their nose because they haven't refined that sensory motor relationship yet. Okay. When somebody has trauma or disease in the central nervous system, it's like starting over again. It's like starting over again. And that is a very challenging thing. Let's take a look at a couple pathologies that are very common to the central nervous system. So we're going to look at trauma from anything from brain trauma, right? Spinal cord trauma or stroke and how strokes work. We'll look at some other central nervous system diseases that I think are pretty popular. And then if you have questions and we have time, I'd love to be able to answer to my best knowledge of what's going on or how we can address this. And I think with this basic knowledge of sensory, interpretation, and then output with motor or autonomic nervous system, we can start thinking of how we design our Pilates classes to be able to optimize both the sensory input to match the motor output, and to also calm the nervous system down so that we can get out of sympathetic mode and actually have more processing in our frontal lobe and in our spinal cord of how movement should feel and how we create these positive movement experiences. So let's jump right into this first one, which is stroke. Now, stroke happens in two ways, and it's basically an infarction of the brain. And what infarction means is that you're killing cells in the brain, right? And cells get killed in the brain by one of two things: ischemia, or lack of oxygen, or by pressure, which also creates lack of oxygen, right? So there can be a blockage or a thrombosis or an embolism, right? These are all terms you might have heard, maybe family members that have suffered from stroke. And these go in and they block the oxygen and it becomes ischemic to the tissue around the brain. So what happens is no matter where it goes in the brain, right, and where it blocks, that's the part of the brain it's going to affect. So if we go back and we think of that real basic map that I did, that if we have a block in the frontal lobe, that might affect us in being able to problem solve or to recognize. If we have it in the back of the head, in the occipital lobe, it's going to affect our vision interpretation. If it's in the parietal lobe, it might affect our sensory. It might affect our memory of sensory and some of those processes. And so we just have to think that not all strokes are the same. Depending where the blockage or the ischemia happens is going to affect a different aspect of our participation in the world. It can affect cognition, memory, speech, vision, movement, interpretation of things, how we hear music. It can change all of those things based on the effect of damaging some of the brain cells in the central nervous system, okay? The other thing that can happen is what's called an aneurysm. Now, an aneurysm is a weakened blood vessel, right? Typically arteries, and they balloon, and that balloon gets big, and if that balloon bursts, then blood is going to infiltrate that area, and it's going to create pressure. Pressure will then cause ischemia, and ischemia will cause infarction to that brain tissue. This is why the latest science in stroke intervention in hospital is amazing, because very quickly, if they can get you in fast enough, they have to determine, is this a blood clot or is this an aneurysm? If it's a blood clot, they can give you blood thinners and thinners that would dissolve the blood clot and would allow blood to get back into the brain. But if it's an aneurysm and you gave somebody a blood thinner, that's a death sentence, right? Because they would bleed out. So they have to be very quick to make that decision on whether they are going to do a blood thinner or maybe have to go in and do surgery or a stent or something to block the area of that ballooning or that aneurysm. And they're getting incredibly good at it. So the first thing that I always tell people is, what are some of the signs of a stroke? All we have to know is that there's increased pressure in some part of the brain that's going to impact function. So they might have a severe headache. They might have blurred vision. They might have slurred speech. They might not make words or make sense of their words. They might lose hearing. They might have numbness in their body, or they might have spasticity in their body, or they might have collapse, or any of those things can happen depending where the insult is to the brain. Okay. So whenever we see that, and I always tell the story where Shelley Power was walking through the studio and she saw one of our clients working with another Pilates teacher, and her legs were all in disarray and feet in straps. And she picked up that there was something wrong there. And we got help and got her to the hospital. Now, it turned out it wasn't a stroke, it was a brain tumor. But it was the same idea. The brain tumor was putting pressure on her sensory and motor part of her brain, and that caused the disorganization. So if you have a client, and we often are going to be the first ones to pick up on this sometimes, that somebody has a disease we don't know about, and they're doing Pilates with us, and all of a sudden they lose control or they lose coordination. When you know that they have the coordination, that's the time to say, is everything okay? And see if they can talk, if they can make a sentence, and then we don't diagnose. So what we're going to do is identify that if there really is a problem, very quickly to get them to the right help, because the faster they get to the hospital for a stroke, the more likely they are to prevent any kind of permanent damage. I had this happen in my own family, where one time one of my family members, senior family members, was having slurred speech, and we immediately got her to the hospital, and it was a blood clot. And they determined that very quickly, and they thinned it out, and they termed it as a transischemic attack, or you might have heard of a TIA. So it was a small blood clot affecting a small part of her speech, and they were able to take care of that very quickly before there was any permanent damage. So that's the key, is very quick intervention, good hospitals, good stroke intervention, and to just watch for signs, especially in our older clientele. While I'm in this part here, I'm going to go into spinal cord injury, but I also want to talk a little bit about brain injury. So brain injury, we could see from TBI as traumatic brain injury. So that would be like a gunshot to the head, a car accident, a bad fall. But there also is called closed head injury, which are like concussions. And concussions are becoming more and more important for us to understand. We used to think that it wasn't very traumatic, but it was the brain sloshing around inside of the skull due to things like whiplash or falls or those kind of accidents. And we want to be able to very quickly respect the fact that these are very serious injuries. And that's why you see now in boxing and football and soccer how important it is that they give these individuals a long period of rest before they go back in the field, because they might look okay and they might look like they can go back in, but they still might be having a lot of difficulties with headache, speech, motor, vision, balance, and even just processing. So a lot of the treatments now, and maybe we can talk about this in one of our cases, is talking about how do we treat somebody that's had a concussion. And I think that would be a very interesting topic. So Melissa, if you make note of concussion, I think we could do a great webinar on concussion and treatment of concussion. And that being said, we're going to go in and look right now at spinal cord injury. So a lot of times we tend to confuse things as a spinal cord injury means that there is trauma to the cord itself. There is pressure on the central canal. So there's an example of a severe fracture of the cervical spine. So the spinous processes are crushed, the vertebral body is broken, and the lower part of the vertebral body being pulled back in the accident has now put a central trauma to the spinal cord. Now, depending how long that pressure is on that spinal cord, just like the brain, will determine if it is a permanent injury or if it is a temporary injury and able to recoup. So again, very quick intervention. The surgeons and the trauma centers have been able to save a lot of people from having permanent spinal cord injuries, sometimes incomplete. But this is a good example of a severe cervical fracture that is doing damage to the central canal of the spinal cord. And remember, the higher up the injury, the more involvement it's going to have in the whole body. So when we talk about somebody having tetraplegia, that would be all four limbs have been affected, it's typically above C5 and C4. And so a cervical injury to C1, C2 also affects respiratory centers. And so it's very hard to get the diaphragm doesn't work. And so you'll see people accessory breathing or on a breathing machine to be able to provide oxygen for their body. And each level down gets a little more function, right? So the lower the fracture in the spine, more function. And again, you can imagine if the autonomic nervous system and the way that things are communicated for the sympathetic system are damaged, that we can see some of that effect as well. And we do, right? So we see things that have decreased sexual function, decreased digestion, kidney function and kidney infections and things like that, that we don't have the normal sensory to be able to interpret or to work through. So there's things that we teach and we work with our clients, our patients, on how to adapt and to function at the highest level, even based on the fracture site or the nerve injury site. One of the interesting things, and again, I think we could make this a beautiful case study as well. You can let us know if any of these are exciting to you that you'd like to hear in the future that we could discuss. We have plenty of case studies in all of these. But when we're dealing with spinal cord injuries, how do we work with them in the Pilates equipment if they have paralysis or if they have partial paralysis? And again, the beauty of Pilates is that we're providing a potentially gravity eliminated orientation, and to be able to have the springs holding body parts up that can enjoy movement and preserve things like blood flow, lymphatic flow, mobility of the joint, protecting the joints, all of those things that are necessary for movement, where if they're in a chair all the time or in bed all the time, they are not getting the circulation that they need. They're not getting the lymphatic drainage that they need, and they can have other things like bed sores and skin damage to the integumentary system. So as Pilates teachers, we can do a tremendous amount of good for individuals that have suffered from some kind of spinal cord injury. And again, I think we can make that its own podcast. Let's move into disease. So as we move into one of the more common diseases that we see in rehabilitation regarding the central nervous system is multiple sclerosis. And if we take the word and we dissect the word apart, multiple just means many and sclerosis means scars. So when we look at a brain MRI or image, these white plaques are the scleroses. That's the sclerosing, right? And so what's happening then is we are seeing that the healthy sheath, the healthy neuron, has these myelin sheaths that cause a saltatory conduction. Saltatory means jumping, and that nerve conduction is much faster in a healthy individual. Where when somebody that's being affected by MS, the body in autoimmune disease is actually eating and removing the myelin. We call that demyelinization. And when the demyelination happens, then the saltatory response slows down, so we don't get the same nerve conduction. Now, this can affect an individual, just like a stroke, anywhere in the central nervous system. So it could affect things like vision, hearing, speech, interpretation, problem solving, memory, motor, sensory, all can be affected by multiple sclerosis. Now, multiple sclerosis is a very difficult disease to understand because sometimes it hits people very hard and stays with them forever. Sometimes it's just one incident in their life and it goes away. And so it's a lot of variability. It's not always a horrible diagnosis. Not everybody has the severe symptoms. I remember years ago, she actually was my babysitter while I was in elementary school. She's about 10 years older than me. And when I came back from physical therapy school and set up practice in Sacramento, she became a patient of mine. She had been diagnosed very young with multiple sclerosis and very advanced, very aggressive. And so by the time I was back in practicing, I was 24, 25 years old, and she was in her 30s and was already in a wheelchair. And so we had a chance. She was one of my first clients to work on the Pilates equipment that had multiple sclerosis. And we were able to do things of maintaining hip mobility and shoulder mobility, spine mobility for her to roll and do things that just helped her overall. Even though we didn't restore strength because of the severity of the disease for her, we were able to maintain mobility and digestion and things like that, that she was surprised that her bowel movements were better, that she felt less bloated, that she felt that she was, could hold herself better and be more aligned by doing her Pilates. So we can do a lot of good in the realm of multiple sclerosis. Another thing with clients with multiple sclerosis quite often is that they will they will overheat. And this is true of Parkinson's as well and other neurological patients. If we take them to a point that we work them too hard, like if we put them on a spinning bike could be great for them, but if we overheat them, then they're going to have a bad experience sometimes for a couple of weeks and maybe put them into a flare from overheating. The beauty of Pilates is that we can have a full hour workout without ever overheating our clients, just by having a solid, continuous movement with assistance that allows them to have a full hour of movement or 15 minutes of movement without overheating. And that's a wonderful gift that we can give to our clients with multiple sclerosis. The next group I want to go with and talk about is Parkinson's disease. Now, remember how we talked about neurotransmitters? Dopamine is the transmitter involved in Parkinson's disease. This is from the substantia nigra, is producing dopamine, and dopamine is a motivation and a controlling neurotransmitter, right? So it motivates us. It also helps control fluidity of movement and speech and even thought. So when we have clients, and many of us, it's one of the leading causes of neurological disease that we have in our country is Parkinson's disease or Parkinson's-like disease. And that basically comes that we are either not producing enough dopamine or that our receptors in the transmitting neuron are being blocked and we're not getting dopamine to the rest of the body. And so when we have that system, we start having things like tremors, delayed steps, slouch posture, slow movement, slow speech, slow thought, and even mental depression can accompany the lack of dopamine. Well, guess what? Successful movement experiences that they can do because we can put them onto machines that they're moving safely on the trapeze table, the reformer, the barrel, the chair, that they can have successful movement. And I will refer you to a video we did years ago. We had a group of clients with Parkinson's disease that came in for Pilates twice a week for about 7-8 years in Miami. So Melissa, I'll have you put that link from YouTube in there for Polestar Parkinson's disease. And you can take a look and hear their testimonies of how they felt by doing Pilates. So movement creates fluidity, and movement also stimulates hope and stimulates dopamine release. So what we would see is that people that were in the program, the disease didn't necessarily go away, right? It's a terminal kind of disease. What would happen though is typically somebody would be in their honeymoon phase of their L-DOPA or synthetic dopamine, and they'd be pretty normal. But as the disease progresses and they use synthetic dopamine, the symptoms get worse and worse and worse again. They have to use more synthetic dopamine, and that has other consequences that lead to more severe limitations, moving up into like a stage 4 Parkinson's disease where they really are incapacitated. And what we found is that over the years, of those 7-8 years of doing the Pilates class twice a week, is that these individuals did not have to increase their synthetic dopamine intake to maintain the same level of function. And we even had somebody that was a stage 4 by diagnosis actually revert back to a stage 3 as far as function by doing Pilates twice a week for a long period of time. So these are some cool things that we as Pilates teachers can make a big impact in the quality of their life. We're not changing the disease process, but we are influencing the idea that movement creates more movement. And when we have successful movement experiences, it shifts also what we think, what we believe. And we know that the self-efficacy and these psychosocial skills are the greatest predictors of functional outcome and are the greatest predictors of how somebody's going to get better or function better in their life, even with a terminal kind of disease. There's a couple questions here. It said, can people with MS get better can get in infrared saunas? And in response to the overheating. The overheating is a little bit different. I think you actually might have some good results with the infrared sauna. I would ask their doctor to make sure. I think that would increase the oxygenation of their blood. It's going to increase their blood flow. That typically only can be a good thing. Overheating typically is when they've worked too hard and they've exhausted all of their energy. So thinking of things like their glucose levels like they would do in a cardiovascular exercise. If they overheat that way, that could lead to a flare or a number of days that they are not feeling good or no energy. And I don't know the exact reason why. I probably should look that up. There was a question by Sarah Edwards. She says, does a masked face in this illustration mean a lack of expression? And the masked face is it's a lack of expression. Like you wouldn't know that they're happy. You wouldn't know that they do look sad and often in that face, because it's just that everything's heavy down. And that's what that masked face expression means. And then Flavi said, can you tell us more about the somatic nervous system? So if we got a couple minutes at the end, I'd be glad to do that. And I think the last thing that I wanted to share with you is a more severe disease that's known as ALS, or Lou Gehrig's disease. And Lou Gehrig's disease is an insult to the nucleus of the anterior horn cells in the spinal cord. So this is our motor cells. And in response to Flavi's comment, the somatic means body. So somatic nervous system typically means the motor nervous system. So it is the nerves going to the muscle, right, from the spinal cord. And so that's what we're talking about here in ALS. These are the anterior horn cells of the somatic motor nerves coming out of the central nervous system or out of the spinal cord. And the disease impacts the anterior horn cell and damages it so that it can no longer send the messages down into the muscle. And so we start having signs of wasting. Wasting means that the muscle decreases, diminishes its size, it atrophies. And a lot of people can survive fairly well with atrophy of their muscles until we get what's called bulbar changes. So the bulbar is the high spinal cord, and that's going to affect things like the diaphragm and other parts of respiration. And this is where the disease gets very painful to be a witness of. If you've had a loved one that suffered from this, is that they lose the ability to swallow, they lose the ability to take a deep breath. They often have fear of choking, and it's a pretty horrific signs and symptoms that we still do not understand how to treat it, other than with steroids or things like that could slow down the swelling around the anterior horn cell. But again, one of the things that we want to try to do is, because somebody with ALS cannot create such a strong contraction, in Pilates, we can modify the load. We can modify the orientation to gravity. We can eliminate gravity. We can create assistance through movement. So we can still provide certain integrity, as I mentioned with a spinal cord injury, of blood flow, lymphatic flow, lubrication of joints, lengthening of muscle tissues, movement of the fascial system are still beneficial to people who are dealing with these severe neurological disorders. So we might ask ourselves in the end, how do we use Pilates to influence the nervous system? And as I mentioned, we have the input and we have the output. So the sensory coming in, we want to influence the sensory coming into the body of these individuals so that they feel like their body is moving and that there is the benefits of movement, even if they can't feel it. So if they have trauma or injury or disease to the sensory part of the nervous system, can we still provide information that maybe they can use their visual or other proprioception to be able to be aware of their bodies in space? If the disease impacts their cognition, for example, let's say somebody has memory loss as well, or they can't process a command. We've worked with a lot of clients that have Alzheimer's or dementia, and outside of having to teach them the exercise like it's the first time every time, they still have the benefit of the movement. The movement still creates all the benefits of the digestive system, the integumentary system, the circulatory system, the lymphatic system, all benefit from the movement. The other thing that in neurological learning, so let's say somebody had a stroke and they're recovering from a stroke, or they're recovering from an MS bout, the increased repetition without fatigue allows for the nervous system to relearn that movement. Remember I said if the brain center or the central nervous center of the memory of that movement is damaged, we have to re-educate it. And one thing that we can hang our hat on right now is this idea of neuroplasticity. Neuroplasticity is that the nervous system is much more adaptable than we used to think. When I was in school, we said if a nerve was killed, it was done. But we've learned since that there is neuroplasticity, that there are new connections being made. We can reprogram movement and speech and those things inside of this beautiful nervous system of ours. So increased repetition without fatigue can lead to re-educating the movement neuroplasticity of functional activity. So it's a great thing. The third one is external and internal feedback. So the external feedback is us. It's the reformer, it's gravity, it's the mirror, it's videos, it's sound, it's tactile cueing. These are all of our our external cueing or feedback that allow them to start aligning what they're perceiving in their body that might be deficient in its sensory and be able to get them to have a heightened internal awareness. That again falls back on our belief that there is neuroplasticity, that we can re-educate ourselves. And think about people that do not have neurological disorders, but have maybe physical impairments, or maybe they are just sedentary and inactive and poor posture. We know that through repetition of successful movement experiences, that their posture can change and their proprioception changes and their awareness changes. And then the last thing I have on here is repetitive functional movement patterns. Try not to get too involved in doing an isolated movement as much as something that could help them. Bringing the hand to their mouth, bringing the hand to the back of their head, putting their pants on, bending over to put socks on, going up a step or down a step, getting in and out of a chair, being able to bathe themselves. Think of all of our movements when somebody's dealing with these level of impairments of how we can help them move better. What are the functional movement patterns that we need to restore? We've got a couple good questions here, and I want to go back into them because we got, I think, about 3 minutes before our time's up. I'm glad that we were able to cover quite a bit of this information, and we will be breaking it down in the future, more particularly by pathologies in these areas, but I felt that this would be a good precursor covering some superficial anatomy and being able to understand it. So Flavi's question about the somatic nervous system, as I mentioned, somatic means body, right? So we talk about somatic movement, we talk about somatic therapy. We're often talking about sort of connecting the awareness of the body, and in the neurological or in the physiological terms, somatic means the efferent nervous system. So this is going to be the motor nervous system, somatic nervous system are synonymous. Rosanna de Guzman said, what if the muscles become spastic? Should they still move, i.e. Parkinson's? Remember that Parkinson's is more rigidity. It's not spasticity, it's rigidity. And yes, they should move. And you can start with very slow and sometimes heavier loads are easier for them to process especially like on the reformer. So a heavier spring might allow them to bend a little bit easier because their muscles are rigid. Spasticity, on the other hand, is saying that there is a signal coming from the spinal cord telling the muscle to contract, but the inhibitory fibers are not working. And so the muscle is turned on and it stays on. And that's why you would see things like what's called clonus, where you see it shaking, or you see the cramping or the spasticity of those muscles. I hope that helps. But Parkinson's is rigidity. MS, spinal cord injury, central nervous system injuries can often result in spasticity. Marianne Parton said, is this study about Pilates impact on Parkinson's disease patients available somewhere? It's more of just our experience with it. The video is available. I'd be glad to talk to you about what we've done. I've also presented it in numerous professional presentations as a pilot study. So that is available, and maybe we can ship at least the synopsis of what we did and what we saw with our clients to you. So that's my time today, everybody. I want to thank you for joining us on the Pilates Hour. We have more to come. Next week, I'm going to be with Beth Kaplanik. We're going to be talking about orthopedic injuries and particularly arthritis. She is a great, great teacher. She's got a course coming up as well. Stay tuned with our activities. Anytime you want to know what's going on in the Polestar world, tap into the Polestar website or subscribe to the Polestar newsletter, the Polestar Life newsletter that comes out almost every week. And we like to have good feature stories about many of you and things that you're doing. If you have a great story you want to share with the world, let us know. We'd love to share it for you. Again, thank you, everybody. Above all things, be kind, and I will see you next week.